Hey, folks, thanks for joining us today. I apologize for the technical difficulties. Today, we're going to have Dr. Jack Lewis with us today to talk about checklists. I want to remind you of a few things. If you could please include your name and license number in the chat, that would be great. We have the QA open for questions. You can also throw them in the chat, whichever one works for you the best. We'll try to get to those all throughout the program. If you are from out of state, please send me an email and I will do my best to get you a certificate as soon as possible. Other than that, Jack, I believe you have the floor.
Cool. Eric, can you hang tight with me for 1 second while I make sure that this works now? And apologies to
Absolutely.
everybody. If I do this, are my slides advancing and do you see
Your
them?
slides are advancing, sir.
Sick. Okay.
All right.
Hello, everybody. My name is Jack, and apparently my laptop is too old to do this effectively, so I apologize. Um, If you have had the opportunity or displeasure of listening to me lecture in the past like 4 years, I've probably talked about checklists at some point or another. This is something that I'm pretty excited about and passionate about, and the good folks over here are giving me the floor to talk about just checklists for the next 54 minutes, and probably won't be quite that long. But this is something that I think is really cool. And what we're going to go through is kind of the power of checklists, how we're using them currently, how we can build them to be effective, and then what we can do starting today, later in your shift, tomorrow, etc., to start using some of these ideas. So I don't have to tell all of you because presumably most of you work in the pre-hospital environment, but we have a super variable, chaotic environment. You might get that call at 3 a.m. from dispatch that there's a car that's about to pull into your station and there's a guy in cardiac arrest. And you've got, 3 minutes to get your pants on, try to wake up and figure out what you're going to do next. You might be over caffeinated, you might be under caffeinated, you might be brand new. And on top of all of this, and like, working your third job and whatever else, when you have to do stuff that's hard, it's really hard, right? It's literally life and death. And there's not too many other jobs, and we kind of all know that it's more than just a job, so I don't mean to, demean it in that way, where you have this super high stress, whether it's just kind of baseline or acute given the situation, and then you layer on top of that a super high cognitive load like anatomy, physiology, invasive procedures. Like that is something that's fairly unique. And it's unique, but it's not entirely novel, right? So, aviation is a good example of another high reliability organizational domain where the stakes are really high. And back in the 1930s, the U.S. is gearing up for the Second World War, and aviation was really kind of going through a developmental period. And I think it was the Army was developing a B-17 bomber, and they had this prototype, and it was called the Boeing Model 299. And they were taking it for a test flight, and the pilot was named Major Hill, and he was the Army Chief of Flight Test, arguably one of the best pilots in the country. And he was starting to take off, and shortly after takeoff, the plane crashed. And it was something to do with the gust locks or the elevators, and the rudder weren't moving. And the next day, this pilot, who's one of the best in the country, was interviewed by the newspapers, and he said that he crashed not because he was a bad pilot, but because there was too much airplane for one man to fly from memory. And I think that that's a really good way to think about checklists in what we do. It's not that we are, if we're using some other resource, we're not cookbook medics. We're not bad at what we do. We're not cheating. We're experts who are using a tool because we have to. because medicine now is like that airplane that's too complicated for one man to fly. And there's plenty of different examples of this, right? We've talked about aviation, whether if you're not familiar with it, there every time you get on a plane, someone is using checklists in the pre-flight time frame. Space exploration, before they are doing spacewalks, they're using checklists. Nuclear power startups, they're using checklists. And even special operators, when they're doing their mission briefing, they are reviewing information in a standardized way that is imperative to review in the same way every single time. And these people are not chumps, right? They're not unknowledgeable. They're experts in their field, and they are using tools to manage complexity. And I can't emphasize this enough that it's not that this is cookbook medicine. This is an expert managing a highly complex task. So you layer on top of that, not only are we facing situations where we need to be reliably performing at a high level, we also are humans and we're fallible. And there's this idea of prospective memory failure. So if you've ever had, and I'm sure, because this happens to me probably once a day, you're doing something uh, in one room, you recognize that, oh, I got to go do that. You get up, the dog runs in front of you, you trip on something, you get into the next room, and you've completely forgotten what you were going into the room for. This is called a prospective memory failure. So we have retrospective memory, which is kind of what we typically think of when we talk about memory, which is something in the past, like what you had for breakfast this morning. That's something in your retrospective memory. Prospective memory is me remembering this afternoon that I have to stop at the grocery store to get tea for my wife, right? That is a task that is in the future that I have to remember to do. It's a mental post-it note that says, in 5 minutes, I need to go and do this thing. In the clinical environment, we have a lot of this, right? Like you say you're getting dispatched to a call and you're like, oh, okay, it's a chest pain. Like, I want to make sure that I get a 12 lead, get some aspirin on board. We'll get a blood pressure, and then I'll think about nitro. And then you get into the house and, you've tripped over 3 dogs and there's some needles around. And by the time you get out, you're scattered, you're sweaty, your heart rate's 120, maybe the patient's being a jerk. And how much of that are you going to remember? We know this isn't something that just is this theoretical idea. We've actually studied it, and we find that experts that have a high cognitive load and then become interrupted, they just forget the things that were being stored in that working memory or that prospective memory. It just happens. It's because we're fallible. Our brain has these open loops that are happening, and those will kind of just get erased when the load becomes too much. So the way to combat that is to have an external prospective memory. Offload it. I talk a lot about cognitive offloading, and this is precisely that. I have written down that I need to get my wife tea later today, and if I didn't, I would definitely forget. And it's not cheating, it's just what we need to do to get the job done. So we've talked about how other reliability organizations do this and use this. Back in the early 2000s-ish, this started to come into medicine more. And the most notable place that it's come into medicine is with this guy, Atul Gawande. He is a great author. He's I believe, an endocrine surgeon down in Boston. And he's got a few different books that he started writing when he was in residency, when he was in training. And what he found in training was that humans are fallible. He's this person, this guy who's doing his best to take care of people. And he's going to fail at times. And he wanted to figure out how to do that better. And in the operating room, that was the scariest place where, you've got someone who you're going to be cutting open, and they found that they Dr. Gwande with the World Health Organization and another surgeon, Dr. Peter Provost at Johns Hopkins, developed a checklist just for before surgery to go through, making sure that they've got vital signs, that they've got the right patient, that they're doing the right surgery, etc. And what they found is that even just a simple pause review of a 19-point checklist had a significant reduction in complications and mortality, which is crazy, right? Like that's super expensive if you want to think about it, logistically or economically. Like that, those complications and mortality is expensive and time consuming and difficult. And if you can just review a piece of paper and that gets better, it's pretty crazy. And I think that since that time, that was like, game changing. Every time, if you've been a part of a surgery, you'll see that every surgeon now performs a timeout, and there's, some sort of a checklist that precedes that surgical intervention. And we do timeouts now before we do procedures in the emergency department. And there are other ways in which checklists have made their way into medicine, and specifically emergency medicine. And when we go back and we review the literature, the studies that have looked at these use of checklists, what we find is that the use of a checklist increases adherence to standards. So we do not miss as many steps in what we're trying to do when we use a checklist. One of the most common places we see this is before doing an airway. So one study looked at using a checklist before intubation, before RSI, and the percentage of omitted tasks went from 45% down to 13%, which is a pretty significant difference. They also looked at it in trauma resuscitations and found that the omitted steps in doing a trauma care went from 25% to 17%. And then when we kind of take that same idea and we apply it to guidelines, when we're trying to say all right, how often are we adhering to a guideline? We see that the use of a checklist will improve guidelines in one airway study from 49% to 70%, or in one trauma study, it went up to, it was another significant improvement in the adherence to the guidelines. So what that looks like, it's not the clinical outcomes, which we'll talk about in a second, but what we can say about checklists in the clinical environment is that we do more of the care that we want to be doing when we offload that prospective memory that can fail. When we do look at the clinical outcomes, we do have that evidence from the surgery environment that says, yes, we do reduce mortality and we do reduce complications. And we do have some signals from other environments like the ICU and from the emergency department where we reduce complications, we have some improvement in first pass success. And actually, I do want to highlight the bottom arrow on that left side. The Air Medical RSI is out of Washington State, and it's one of the first studies that really demonstrates that a pre-RSI checklist improves clinical outcomes in the form of first pass success when using a checklist, and we'll talk more about that study a little bit later. But in the past 10 years or so, most of the evidence is kind of equivocal when it comes to clinical outcomes. We look in the critical care environment with doing airways or trauma outcomes in the emergency department, and the checklists improve adherence to the guidelines, but they don't necessarily improve the clinical outcome of the patient, which is, I think, part of the reason why it hasn't gained as much traction, the use of checklists, that is. And I want to kind of pause on that moment for a minute because I do think it's important. And use an anecdote where recently I was in the community in a critical access hospital, and then a patient come in who I identified was having an aortic dissection, which is for any of the EMTs in the room. It's the big blood vessel coming off of the heart is coming apart, exploding, and it's really bad, really not great, especially if you're far away from a surgery or a surgeon who can manage that. And so I have a checklist for that. I have a book that I use that I'll show you in a minute. And I run through the steps and I do all of the things that I can do as quickly and efficiently and comprehensively as I can. And the checklist helped me to do that. That patient is still at a super, super high risk of mortality. And there's nothing that a checklist is going to do to change that. And I think that that's okay. I mean, it's not great for the patient in that circumstance, but my point is that we don't need a super big signal in clinical outcomes to tell us that checklists can be useful. I think the evidence that we have demonstrates that where we use checklists, we perform better. And that's the takeaway that I'd like you to kind of bring into this next part, which is thinking about how do we maybe do this in the pre-hospital environment? Like there are some services that are doing RSI, like aeromedical services that are utilizing checklists. But what might this look like for us in kind of the everyday pre-hospital medicine? And to consider that, I want to go over a couple of different ways that you can use checklists. So there's a couple of different buckets, and we'll go through these one by one. The read and do, the challenge response, and then kind of the crisis cognitive aid. So the first one's maybe what you think of when you think of checklists, like the most typical approach. It's the read and do. You've got a task that maybe you don't do very often, or it's more complex, or you just want to make sure that you're hitting all of the steps. And so you read each line, you do the thing, and you move on to the next one. My slides, I had Gemini, the AI model, make my slides, and if you see funny things, well, that's why. One of the examples that Gemini thought was pertinent was mixing a norepi drip, which most of you could probably do from memory. But if you're training, for example, and you want to make sure that every time you train, you're mixing a norepi drip in exactly the right way possible, that's a great time to use a read-do checklist. I think maybe a more applicable version of this would be something that we really don't do very often, like epinephrine dosing in a code. And while this isn't necessarily a read do checklist style, it's more of the critical reference. The idea holds true that there's something that is difficult that is done infrequently, and we have a step-by-step guide in how to perform that task. The next example of a checklist is a challenge response model. And so this is a similar sort of thing, except it engages the team a little bit more. So this is something that this is how the pre-surgical checklists work. Usually it's not the surgeon, it's like a charge nurse or someone who's running the checklist, and then various members of the team are responding to that person. And in that Oliveira study that I referenced from last year, the RSI in Washington State, they noted that sometimes the pilot would be the one running the checklist, which is kind of interesting because it's a member of the team, but not a clinical member of the team. So the clinical members can be really engaged in what they're doing. But this is a really good way to force a timeout, to engage the entire team and have kind of dual confirmation that something is being done. And let's see if this works. This is an example of a checklist that I made for residency for RSI. All right, so suction's on, BVM's ready, Eric, can you hear this okay? Or can someone just like give me a thumbs up, or Eric yell through the hallway? Can you guys hear this audio?
We can hear it.
Yes.
Okay, perfect. Thank you. So what this is going to be, this is a real RSI that I did with one of my co-residents in residency. And this checklist that I have up on the screen right now is my my like takeoff checklist functionally. And this is everything that I want to make sure has happened immediately before we're pushing medications and paralyzing someone to take their airway. And the way that I used this is in the kind of call response format. So you'll kind of so suction's on, BVM's ready, app box is on, wide scope is on and plugged in. Yes, plugged in. Vascular access is checked. What do we have? 218 and a 20. And Wes, you're happy with your positioning? Do you need anything else? Nope. What do we have for induction? 30 of accommodate, 100 of raw. And I've got push Giuseppe in my pocket. Last set of vitals, blood pressure is cycling right now. Oxygen's good. Any other questions or concerns before we go? All right, let's just see what this pressure is, and then we'll go for induction. So straightforward, right? That took 30 seconds. I've reviewed major concerns about what's been prepared for this patient before we undergo a high risk, relatively low frequency procedure. And I've engaged the room, right? Like I've had multiple team members participate in that, which gets everybody on the same page, shares my mental model of what's happening. And I think it works really nicely for certain environments. Those do tend to like take a little bit longer. It is a little bit more of a hard stop. And so I think that there have been some of the checklist studies that have been done have tried to utilize this style of checklist and have encountered cultural barriers and resistance to it because it's a little bit more of a chunky tool than some other tools that you might use. For example, the last and kind of the sort of checklist that maybe it's more of a cognitive aid really, that I use the most and think about the most is a crisis manual style checklist. So this is for those moments when you're doing something where you just want to make sure that you're going to do everything right. This is the any sort of critical illness, sick person. How do I proceed through this patient encounter, making sure that I check all the major boxes? There's a lot of different settings where this might be useful. The one that I've been focusing on a lot is cardiac arrest. And it's something where, is it fairly intuitive? Yeah, but it's very algorithmic and it can become fairly complex. And there's no reason that you can't offload that complexity into a tool to use in real time. So this is an example of, this is the anesthesia crisis manual. I'll show you in a second the resuscitation crisis manual. This is the actual checklist that as a physician, I keep with me whenever I'm working. I have the electronic version of this one because this is meant for anesthesiologists and CRNAs in that clinical environment as opposed to emergency department docs or critical care docs. But this is a anesthesia cardiac arrest checklist that you can buy and use. And what's interesting about it is that it just takes you step by step through what you need to do. It's not the AHA algorithm that might be more helpful for some of us, but what it aims to do on the left side, you've got your steps in order of what needs to happen with, descending priority, right? So, making sure the patient's in cardiac arrest and then doing compressions, that's just the most important thing. We all know that. Then on the right side of the page is kind of the slower thinking, get a little more in depth into what might I need to be thinking about during this process, like as you kind of find that time in your 2-minute cycle to think about it. So that's, very specific to that environment for anesthesiologists or CRNAs who find themselves in the unusual event of managing cardiac arrest. This is what I use frequently, and it's called the Resuscitation Crisis Manual, and it's the same thing. It's the emergency flight checklist for emergency providers. And it's got a number of different kind of critical patient encounter style pages, and this is the example of the status epilepticus one, and it just takes you through step by step the most important things and kind of how to accomplish them. And then on the right side, a little bit more in depth, just what you need to know in the way that you need to know it for managing that critically ill patient. Uh, and I love it. It makes me feel like, do I know how to manage status epilepticus? Sure. But when I, true story, show up to work and am taking my jacket off and see on the camera of the waiting room a limp child seizing in the arms of a parent that then gets, brought back into the room like an hour and a half away from definitive care. I haven't had coffee yet. Like, I am going to feel more comfortable managing that patient with this in my back pocket. So I don't know why we don't do this for pre-hospital medicine, right? Like, doesn't this kind of make sense that we provide some sort of concise, evidence-based, protocol adherent guideline for how to take care of critically ill patients? I think that uh, like this is my idea of this is that as a medical director, I work with you to distill down the most essential information about a particular thing and create a form for it that you can use in your environment. And then you can always reference that, whether you're training or in real time. And it's always going to, be geared for working in the right way at the right time. I think that we can do this for any number of different things. So take needle thoracostomy. Uh, I can tell you that this is hard, and we don't often do this well. But if you could offload from your brain all of the stress of remembering the critical steps of how to perform this, and then you can use this to train and in the same exact way translate that to real patient care. There's no reason that you shouldn't have some external brain for doing something that is this difficult and this infrequently done, right? Likewise, I think that it makes all kinds of sense to use these crisis manuals or checklists to pre-plan during a response. So, an example I gave was you get dispatched to a cardiac arrest and you're, hopping into your ambulance, you take out your cardiac arrest checklist, and you can just talk through the first 2 minutes, the first 5 minutes, the first 10 minutes, right? It's cardiac arrest. You know what you're going to do. You can just review that with yourself and your partner, have a shared mental model, have a discrete plan that you know exactly what you're going to do, the first steps that everybody's going to take, and then continue to use that same reference in real time during your patient encounter. I think if you've got a whole team, this could be something that is just what one person does. If you, uh, Portland, looking at you, I don't know if anyone's on, but when you've got that ambulance engine company and EMS officer showing up to a call, no reason that someone can't stand at the foot of the bed and just calmly, provide a narrative about what the next goals are, summarizing the events that have already occurred, reviewing medication dosages, reviewing, appropriate IO placement, team responsibilities, etc. I think that this makes all the sense in the world. And then when you get to things like the H's and T's, I still look up the H's and T's. Like, I know what the H's and T's are, but remembering them in real time when you're like, okay, fourth round of CPR, I gotta start thinking about, it's not easy. And I don't know why we don't make it easy for all of the main EMS paramedics that are out there. And this girl is also running a code with her twin, apparently. But I think that it's also like we're not always going to have that Portland model, right? Sometimes we're going to need to figure out how to do this in a way that works for everybody, whether that's a badge buddy, smaller card that pops out in the monitor when you start working. Like this needs to be something that works for you in your environment. So how do we get there from here with the creepy AI main moon hovering in the sky? Well, I figure I'll use, we've got plenty of time still. Let's just kind of go through what it kind of looks like to maybe make one of these checklists or make one of these references. So I think the first step is that we have to define the scenario. We have to define the time when we want to be using this, those high acuity, low occurrence events where the cognitive load is going to be particularly high, and we know that our heart rate is going to be elevated, whether that's cardiac arrest, crikes, needle thoracostomy, what have you. Um, then we need to seek out the best way possible to do that. I think that starts with our protocols because that provides the scope and breadth of how we deal with that. But then we can incorporate any other information into that we want to, particularly what equipment do you have? What crate kit do you have in your bag right now? And do you know exactly what's in there? And if you're planning on doing a scalpel finger bougie technique, which we'll get to, do you have that equipment bundled together in your airway equipment? Like, does that make sense? And then we got to take all of that and distill it down. And it needs to come into a form, a distilled form that is not, the extraneous needs to go away. It can be, you could maybe create like a little backup manual or text or whatever that really like cites all the sources and provides the lengthy explanation of how to do the task that you're talking about. But ultimately, we need something that our brain can handle in real time under stress. And then we need to put that into a form that can be accessed in real time and under stress. So, like I said, maybe this is like a binder, maybe this is a little book. The resuscitation crisis manual that I've been talking about, I should have brought it with me, but I didn't. It's like an 8.5 piece of paper folded in half, like just fits in a bag, but not in your pocket, which makes sense for a hospital environment, but does not necessarily make sense for the pre-hospital environment. And I think that some of the things like the checklist that I showed you during my the intubation, that lives on my badge. It still lives on my badge. And I think that it makes sense that you consider precisely what your environment is and create a tool that fits that environment. So let's go through this. Let's take a couple minutes and kind of walk through a little bit of what this process might look like. So, surgical cricothyrotomy. I can tell you, I saw a Topsum name or two when I was in medical school and I was working at Topsum. I would get into the back of the ambulance after not having worked for a little while, and I'd start pulling out, like, all right, where's the crite kit? Pull out the crite kit, look at the individual components of it, sit, like, move over to the right side of the patient where I knew that I would sit, and just close my eyes and walk myself through the task, right? This is a high acuity, low occurrence event that you could be asked to do like right now. And it's always going to be difficult and it's always going to be stressful. There's no reason we can't make that easier. Main EMS protocol, which we have here, does a great job of walking through precisely um, how to do this. It's just a lot of words, right? Like I am not going to be able to read this in real time when I need to perform this skill. Also, I might not have this equipment. So let's take those protocols and now let's dive a little bit deeper. Let's find some reference texts. Like this is Robert and Hedges, emergency medicine procedures, a paramedic textbook. Let's watch some videos, check out some blogs. Let's like find some primary literature. Let's gather all of the information that we want to go into the best possible way that I want to think about this procedure for me, for my service, for my specific instance. Um, and then let's distill that down. Like, what is this going to look like if I take all of that information and put it into what I know to be my clinical environment, which is going to be the back of a moving ambulance, maybe in low light, maybe with specific equipment, maybe with a paramedic partner who's going to know how to help me, and maybe not. Um, what do I need this to look like? Given all of that, I'm going to take my ideas of best practice, distill it down, and put it in that environment. What do I want that to turn into? So this is like the idea that I had started to work with. And I think that this is still rough and it's still probably too much. But this is the first draft, right? So let's take this. The idea is that it's going to be just enough to be able to reference and get me where I need to go. And I want to add pictures in there, which I don't have yet. And it's going to be simple enough to use, but comprehensive enough so as to not miss steps. Once we get there, we've added kind of some guides as to, um, you know, like the picture, like what do I need a picture of? What don't I need a picture of? Run it by your colleagues. Who thinks that this is a good idea? Eric can tell you that I bounce stuff off of him all the time to see if he thinks that that works or doesn't work. And then start trying it, right? Use it in a training. I've a couple of times recently been doing cardiac arrest simulations, and I'll pull out the cardiac arrest checklist that I'm working on and look at it in real time and try to think, does this make sense? Like, is this too much? Is this too little? Like, is this accomplishing what I want it to accomplish? And then introduce it into the real world environment. If it's like in this example in a crike, you might not get too many trials of that in the real world, and you're going to have to like increase the sim value to be a little more critical of that tool. But then you need to come back and with your triplet friends, uh, review and refine. This has to be an iterative process where you don't just do it once and forget about it forever. This is going to take some tweaking. And it's going to be a group effort, but I think as specific to your environment as possible, the better the tool is going to be. So to that end, I've showed you, a few of the different like draft 0.0s of these checklists that I've worked on over time over the past 3 years or so as I've given various lectures. And I've kind of created a list of things where I think that this might be helpful. But this, I think, where I'm entering an era where I want to start working with folks to create these tools that could be useful. When do you want a reference? When do you feel like you want that medical director in your back pocket to provide that little bit of reassurance that says, yes, this is exactly how we talked about doing this thing? Because I don't think it's that hard, right? Like I think that you could sit down and you could knock out one of these in a day. That could be your QI for them or your training for the month, right? Like you start with the main EMS protocol where you ask some people to like find a couple of references and you come into shift, you sit down, and you can knock this out. And it's not that hard. I made all of these in Microsoft Slides, right? Like, I think that this is eminently possible. We just have to kind of make the effort and start working on it together. So bringing it all together, I think that this is something that would benefit us. I think that we've shown that checklists improve adherence to the standards that we set for ourselves. We have shown that we perform better when we use them, and sometimes they even improve clinical outcomes. And we've started to use these in other parts of medicine, and there's no reason that we can't start to do it in pre-hospital medicine as well. There's a bunch of different ways that you can do it, and it's just going to be picking the right form and environment to do it for yourself. And I think that that's something that we can work on. So if you would like, right now, I've got the cardiac arrest checklist. I would be glad to send to anybody to, get some eyes on. If you have thoughts, feelings, you want to see some of the other, examples that I posted, or if I didn't cover one that you think like, oh, I really like, I had this call and I really could have used a reference in that moment. I'd love to hear about it. And we'll be glad to keep you updated on this journey as I try to make some more cognitive aids for folks in doing pre-hospital care. And I recovered and finished a little early. So if you have questions, or if there's been anything that's popped up in the chat, I'm happy to address some of those things now.
Well, currently we don't have any questions in the chat or the QA.
Yeah, that's fine.
From the chat, thoughts on using checklists as a device for ruling out pertinent negatives for a condition.
Yes, love it. Let me find here. So for example, one of the things that scares me is pregnant people. And when I was thinking about, I try to teach the things that scare me sometimes. And so one of the times that I was teaching about OB, I was thinking like, okay, what do I need to remember in my history taking that's a little bit different than every other history taking that I do on a day-to-day basis? And so this is kind of, you can see on the right there, some of the conditions that oh, this doesn't really cover it. If I hadn't had to email this to Mike, I could pull up the other side of it, where the step-by-step process includes information gathering based on that certain patient condition, right? Like how many weeks have they had prenatal care? Has there been discharge or bleeding, etc. Um, because I think that certain, and this could be, you could like super low hanging fruit would be like the C-spine clearance. Like that's right for the picking, right? I think that it makes a lot of sense, particularly as you're learning to offload those things, but even more sense for less common patient presentations like obstetrical or gynecologic emergencies, um, where you're going to need to pull from a deeper part of your brain and might not be able to collect all that information that you want. Seeing the other question about protocol evolution app extension, yeah, I think about this all the time because my most common tool is the phone, right? Like we all have our phones with us all the time. I think that it would make really good sense to have this as an app. And there's got to be someone here who's somewhat familiar with Hand Heavy, which is a product that will develop something like this. I'm not intimately familiar with it, but there are ways that this has been commercialized at the moment. And I think that it would be great to have it as an app. I don't have the savvy to do that as an individual, which is why I think the first step is developing the tool itself and then figuring out how to get it into the form that's going to be most functional. And I totally agree that an app or electronic reference is likely going to be one of those most accessible, um, uh, you know, uh, formats. Um, but at the moment, I'm a dude that knows how to like use some free uh, PowerPoint software. Um, so I think that completely agree. The future of this would be something that's a little more functional. But if we can work on creating what that looks like first, then we can figure out how to translate it to that sort of tool. Yeah. Yeah, completely agree. So the next question is kind of like, an evolution of this and like, having AI or like some sort of, and this could be like a telemedicine sort of thing, right? Where say you're practicing in a low resource setting and you've got a camera in the back of your ambulance and you can just call into your real-time medical control and say like, hey, I've got this and I like, what do I do next? And then having some, you know, some whether it's, software or AI or another person in another place um, providing those prompts to do the next thing. I think that there's a lot of possibility for how this could evolve. Um, yeah, it's all in the name of the cognitive offloading, right? Like, how are the ways in which we can get stuff out of our brain and into a tool so that we can focus on what's immediately at hand.
That looks like it, Jack.
Cool. Thanks, guys. Thanks for listening to me rant about my favorite thing. I appreciate it.
Jack, thank you for the work today. Thank you all for attending.
Have a good one, guys.